Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. Today we are offering 5 conversations from episode 40, our review of last week's Paris NASH conference, plus from the vault, our most downloaded conversation ever, which comes from Paris NASH 2021. This conversation starts with Scott Friedman discussing the session he shared with Fabio Marra at Paris NASH, discussing the link between fibrosis and regeneration. Scott points out that the liver's ability to regenerate is unique among organs, and that a pivotal question, how it does so, arises every 10 years with different answers, none of which turn out to cover the question adequately. He goes on to note that injured livers are less likely to regenerate than healthy ones, and that regenerative livers are less likely to create scar. He notes that while we do not know which of these phenomena comes first, the answer is likely to have a broad range of implications, not only for liver disease, but for a range of other organs as well. In response to the question from me, Scott says he considers it more likely that regenerating liver tissue sends a message breaking down scar than the reverse, and bases this on the natural history of treating viral hepatitis. Jörn Schattenberg asks the degree to which the underlying etiology disease causes the response, and Scott states that the response is fairly common across etiologies, but, as he notes, the devil, that is, the differences, are the details. The rest of this conversation is devoted to Laurent Castera and his section with Dr. Mark Luthier from Singapore about the use and limitations of NITs. This talk evolves from a case study about an individual patient. Laurent's point, which he expressed more eloquently during the episode than I do here, is that we need a range of tests depending on the question we're trying to answer, initial screening versus staging versus monitoring, and that the entire issue runs the risk that overwhelmingly frontline treaters are not aware of these issues and will not manage the test properly without a lot more training. In this context, he cites the value of FIB4 as a simple test to deliver, and also its major drawback related to ages and cutoff levels. Along with NASH-TAG, Paris NASH is one of 2 famously small, famously science-based, publicly available events every year. We cannot really cover the entire meeting in a single wrap-up episode. Frankly, we've never been able to do so. But this conversation neatly captures some of the key dynamics in the meeting, and particularly ones around NITs. It's a lot to digest, and frankly, I had to chew on it multiple times before I wrote our summaries. So sit back, listen, learn, enjoy, and when you're done, join the dialogue in our LinkedIn discussion group. So with that, let's dive into our conversation. Paris NASH is a pretty dense conference. Instead of going through the whole thing section by section by section, I'd like to take a slightly different approach. First of all, each of our 3 KOL guests, well, Jörn's not a guest, Jörn and our 2 KOL guests each presented at the meeting. So what I'm hoping each of you can do first is take a couple of minutes and talk about the work that you presented there and share that with our audience, and then we'll go back and share a couple of other things about the meeting. Brave one, go first.
Scott Friedman.
I'll jump in. One of the things about Paris NASH that is very exciting is that Arun and Laurence, who are the 2 organizers, always pick really cutting-edge topics and also some provocative topics and questions that engage people who think about the disease a lot. So this is not a meeting for amateurs, so to speak, because the topics are very nuanced and difficult to answer. For me, that's very exciting. Now, they asked me to speak about something that I'm also very interested in, which is the link, if any, between fibrosis and regeneration. And so I had the pleasure of sharing a lunchtime session with Fabio Marra. For my part, I really tried to emphasize how little we know about the link between why fibrotic livers don't regenerate well and why regenerative livers don't develop fibrosis as they regenerate. We don't know what the signals are, and it's worth reminding ourselves that no other organ except liver has this remarkable capacity to regenerate and regenerate over and over again through repetitive liver injuries over a matter of decades. You know, I also pointed out somewhat cynically that I've been in the business for almost 40 years, and every 10 years there's another fashion of what drives liver regeneration. It started with epidermal growth factor, EGF, HGF, and then it was insulin and glucagon, then it was stem cells, then it was epigenetics. I'm not sure what it is now, except maybe single-cell technologies revealing subsets of cells that are particularly regenerative. The point being that we have a lot to learn, and we had a very stimulating conversation which made us all realize that there are huge gaps in our knowledge in NASH and in all diseases to explain why the injured liver doesn't regenerate as well. And of course, the implication is if we uncover those signals, we have new therapeutic targets that may enhance regeneration. And if we enhance regeneration, that may ignite an endogenous program to cut down or degrade scar. Conversely, if we develop therapies that degrade scar, we may ignite an endogenous regenerative program. So there's lots of prospects for progress based on new technologies, but lots of gaps in our knowledge that need to be addressed in the coming years.
Scott, if you had a hunch, which one of those 2 prospects that you just raised would you consider more likely?
I actually think that if there is a program that comes from a regenerating liver or liver cell or subsets of liver cells that tells the liver, break down scar, we don't need you anymore. Well, the reason I say that is, or I leapt to that answer, Roger, is because we know in the natural experiment of treating underlying viral hepatitis, which are drugs, whether hepatitis B or C, that solely clear or suppress virus in hepatocytes. They have no antifibrotic activity, yet when they exert their activity in suppressing the virus, fibrosis melts away. So there must be signals coming either directly or indirectly from hepatocytes that have been cleared of the virus that are saying it's now time to regress scar and restore the normal architecture, which may be a default once you get rid of the injury to hepatocytes.
Jörn Schattenberg.
No, unfortunately, I missed that lunch session, Scott. I would have loved to join, but I missed parts of the first day. And I guess you mentioned the Hep C example, which is great. My question would have been, how much is disease specific and how much is just, the pure preserved mechanisms of scarring the liver, which is probably throughout all different insults very maintained. Do you think the underlying etiology matters to a big degree, or what's the data saying here?
It's certainly across etiologies that cause chronic liver disease. My first answer is the etiologies are not so critical because the liver has a major way of repairing and restoring regeneration. Having said that, I've also come to recognize that the devil is in the details, and that recognition comes from the use of single-cell technologies that have defined subsets of different cell types that subserve different functions. And they may be that the response to injury and the clearance and the regeneration that follows may be subtly different between hepatitis B, hepatitis C, alcohol, NASH, or other diseases. I would conclude by saying I think these processes are much more similar than different across etiologies, but there may be subtle differences that we'll learn about as we uncover some of the answers to these questions. Also, if you were alluding to the prospect of regeneration in other tissues, I think that's an even more vexing question because it comes back to the issue of why only liver? What is there that's unique about liver that you can surgically remove 2/3 of a healthy liver and the liver will grow back? And that certainly won't happen in lung or kidney or any other organ. So even if there are shared mechanisms across different liver diseases, they're less likely to be shared across other tissues that get scarring.
Fantastic question, fantastic answer. So Laurent or Jörn, whoever wants to dive in and let our audience know a little bit about what you were speaking about at the meeting.
Laurent Castera.
I had the pleasure to chair again also a lunch session with Dr. Mark Mutia from Singapore on the pitfall and limitation of the use of NIT in NASH patients. And I have to say this was a very interactive session, and we started from a simple clinical case, and we went all the way to show and to share with the audience how we could use these NITs in the different aspects of the diagnosis and the follow-up of the disease. So first, of course, you can use a simple test like FIB4 to enrich your population and to spot among patients with risk factors those who are likely to have advanced fibrosis, and that should be referred to an expert center because, as you know, most of these patients are seen either in primary care or for some of them in the diabetes clinic. One of the hurdles to implement, because the good news is now we have 4 international recommendations on sequential algorithm using FIB4 as first test, and then a more specific test like ELF or liver stiffness using VCTE. And these recommendations are aligned, which is a good sign, and not only association like, of course, EASL, ASL, the AGA, but also the endocrinologists with the QZ recommendation. And I think this is a strong signal to the field and the way to go. But one of the barriers to the implementation of this algorithm is a lack of awareness of many colleagues, especially GP. They're also overwhelmed by the burden of patients. Even though they see some of these patients with metabolic risk factor every day, usually they deal with hypertension, with diabetes, with obesity, but they tend to scotomize kind of the liver. And we clearly need to work on raising the awareness of the liver and showing that very simple tests like FIB4 that can be implemented tomorrow in your clinic can be used. And the major advantage of FIB4, not only it's very easy to calculate at the bedside or in the outpatient clinic, but also it's very cheap and has high negative predictive value. One of the only drawback actually is to adapt the cutoff according to the age. If you're targeting population that are above 65, so instead of using the 1.3 cutoff that is currently recommended, you should probably use a higher cutoff like 2, for instance. Otherwise, for instance, in France, we started to implement with the labs automatic calculation of the FIB4 by the labs when they're seeing patients. And this could be a way to leverage the awareness and the use of this algorithm.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. We'll be back next week with coverage of the FDA's 2-day NIT workshop. Until then, stay safe, surf on, and enjoy the last weekend of what is the summer season for most of us in the Northern Hemisphere and the winter for those in the Southern Hemisphere. We'll see you back next week. Bye-bye now.